Jackson just got reinstated.
Well, not officially. Nervous?
Yep.
Yeah, me too. Don't worry about it. We'll figure it out.
I'll see you in there. Just okay?
Not okay. Anyways, I thought that was kind of a cute and lead into a communication discussion. So the aim of this project is to improve patient safety by improving communication processes. The project seeks to utilize current evidence to demonstrate the importance of effective and meaningful communication on patient safety. Most of the research out there focuses on causes of miscommunication and has offered little assistance for improvement. So this project is going to focus on articles that provide us with some evidence-based suggestions to improve our communication. So I want to begin by asking a few questions, and I'd like you guys actually to let me know your thoughts. How would you describe healthcare in America? Would you say safe or unsafe?
Well, I would hope it's safe, but I think that's probably not completely true, depending on where you go.
Okay.
I would do that.
And how about how common are adverse events? Would you say rare, somewhat common, or prevalent?
I'd say somewhat common.
Yeah, me too.
Yeah, because it happens, we're all aware of medication issues, communication issues, you know.
Right.
We're daily dealing with the outcomes of those things, so it's somewhat common.
And how about the last statement? Would you say that's true or false? Generally, we're doing everything we can, and unfortunately, mistakes are an inevitable part of life.
True.
And so this slide is what the experts have to say on that. So despite recent improvements in healthcare, it remains unsafe and adverse events are prevalent. Patient safety, not determined by individuals, but rather by poorly designed systems, make errors more likely. And strong systems can prevent human errors and improve patient safety. Here I have some statistics available, recent studies, which I found these very surprising, and I answered the previous questions we talked about kind of the same way. Recent studies estimate that over 250,000 deaths per year result from medical errors, making them the third leading cause of death in the US. Research implicates that communication deficits and miscommunication are a leading cause of preventable medical errors. And according to the Joint Commission, ineffective handoff communication is the leading cause of sentinel events, which were reported between 2011 and 2013. The goal of this project is just to increase awareness of the patient risks involved because of gaps in our communication, to encourage staff to recognize their role in patient safety, and to overcome the idea that errors don't happen. That was one of the things I learned going through this when I was reading the article in regards to experts and healthcare opinions, is we do tend to think we're doing as much as we can because we are doing so much. And the key is to recognize that there are systems and things we can do to improve. Also to lay the groundwork for communication process improvement initiatives and to provide evidence-based measures that can improve our strategies. The rationale for the project, improved communication will not only benefit patients by reducing medical errors and patient harm, but has also been shown to lead to a lot of other things which we are all working on: improving patient and staff satisfaction, reducing readmission rates, reducing length of stay, healthcare costs associated with it. Also, patients have been shown to feel heard and empowered and to ask questions when they don't understand. And communication tools have been shown to result in an improved exchange of information, efficiency, and competence. So here we get into some of the evidence. This article or study was named SBAR Communication and Patient Safety. It was an integrated literature review. The object of the study was to analyze literature addressing SBAR use and determine its effectiveness in handbar communication. We're all pretty familiar, I think, with SBAR, Situation, Background, Assessment, and Recommendation Framework. It was created by the US Navy for use in critical situations to provide a way of communicating important information quickly and effectively. It was used in high-risk situations such as the Navy's nuclear submarine industry. and it allows all users, regardless of their level of command, to communicate effectively on a common structure, which is the key to using standardized tools and to being effective with our communication. The results of this study found 4 reoccurring themes. It provided a common language for communication of key patient care information. It increased the confidence of the speaker and the receiver during handoff report. It improves efficiency, efficacy, and accuracy of report, and it improves the perception of effective communication. Here I have a sample of SBAR in use. So a nurse wants to report a change in patient condition to a physical therapist who's scheduled to work with the patient later in the day. Situation: Tom, this is Lisa in ortho. You're scheduled to do PT with Mr. Jones in room 5 this afternoon at 2 o'clock. I wanted to give you an update on his condition as it might change your plans for today's therapy session. Background: Mr. Jones had hip surgery 2 days ago and has only been out of bed since his surgery once. He's been complaining of intense pain in the area. This morning the incision is red and there's an increase in amount of drainage. Infection disease has been consulted. I'm thinking that Mr. Jones has a surgical site infection. His labs are off this morning. He has elevated white count. Recommendation: Tom, I would like to recommend that you either postpone time with Mr. Jones or make his first session very brief. So I use that example because it shows how it can also be used with ancillary staff, like interdepartmental handoffs, which I think are beneficial as well. This study, adapting the IPASS handoff program, was used in an emergency department for intershift handoffs. It aimed to explore what types of modifications would be needed to this framework to be used in the ED. IPASS stands for Illness Severity, Patient Summary, Action List, Situation Awareness, and Contingency Plans and Synthesis by the receiver. It was a systematic review. One of the things I found interesting about this study was that it also included a mixed method needs assessment at an ED that already used a semi-standardized method of doing handoff, which in communicating with our nurses, it sounds like that's similar to what we're using. They say somewhat standardized, not always the same. They do use a checklist, so I thought similar to what we're doing. And it found that with modifications for context of the ED that it was effective. Here is a sample of what the IPASS stands for over here, and then on the other side, a handoff, and I'll go over that portion with you. So illness severity. Okay, this is our sickest patient. He's a full code. AJ is a 4-year-old boy with a history of 26-week gestation, admitted with hypoxia and respiratory distress, secondary to a left lower lobe pneumonia. He presented with cough and high fevers for 2 days before admission, and on the day he presented to the emergency department, he had worsening respiratory distress. In the emergency department, he was found to have a sodium of 130, likely secondary to his volume depletion versus syndrome of inappropriate secretion of antidiuretic hormone. He received a fluid bolus, was started on oxygen at 2.5 liters, and is on ceftriaxone. Action. Please look at him at approximately midnight and make sure his vitals are unchanged and his oxygen saturation is stable. Check to determine if blood cultures are positive tonight. If his respiratory status worsens, please get a chest x-ray and check for a developing effusion. And then the receiver synthesis that back. So okay, AJ's a 4-year-old ex-preemie admitted with hypoxia and respiratory distress, secondary to left lower lobe pneumonia. He's on ceftriaxone, oxygen, and fluids. You want me to check on him at midnight and make sure he's stable and check his blood culture. If his respiratory status worsens, I'll get a chest x-ray. I think I have it. So you can see how it's would be effective. This one, 4 evidence-based communication strategies to enhance patient care. I did share this with a few people in the hospital. I found it very interesting. This had several different studies utilized to come up with the information. And what it found is evidence showing that these 4 communication strategies help family physicians improve patient satisfaction without significantly affecting their length of visit. And they're very basic, things like taking a seat, This was shown to increase patient perception of the visit. Patients felt that the visit lasted longer, even though it didn't. Patients were also more likely to feel that the physician explained things better, just because he took a seat in the room with them. Also, it talked about expecting there to be more, assuming that a patient has more to address than they're initially willing to state. One study also showed that patients opened up more when it was asked, is there something else you'd like to share today, rather than, is there anything else? Just simple wording made a difference. And then it says here, bathe your patient. That stands for background, what is going on in your life, effect, how is it affecting you, trouble, what troubles you the most about your situation, and empathy. That sounds very frustrating or scary, for example. When doctors used that, it was shown to affect how patients felt empowered and listened to, and improve their overall satisfaction. And then lastly, of course, be reassuring to the patient. Some of the evidence in that portion of this article showed that patients felt more reassured by a physician sitting next to them and having a conversation, even in comparison to doing additional lab works and tests when they weren't sure what was wrong. Just having that matter-of-fact person-to-person conversation with them, explaining differential diagnosis when they weren't sure and what they were looking at, and then of course following up with results.
So Angela, because you round with the providers here, how do you think they're doing on those things?
I've been noticing Nicole's, she frequently tries to sit down in the rooms and visit with them. Dr. Hahn too, he'll sit down and, take a seat and talk to the patient. I think overall we have room for improvement, but we are utilizing some of these things, so I thought that was.
Because like our PRC scores are not really where we need the
Right.
providers to be, so
Right.
the patient's perception of their communication or whatever
Exactly.
isn't showing that,
And
so
that was
it's kind of like-
specifically something in this article I found interesting, is because it said when the multidisciplinary team rounds, you have all these people who come into the room and they're all standing. How do you sit down? But it was saying that that is something that they recognized as being an obstacle, so to speak, in this particular
Yeah, 'cause
situation.
there wouldn't even be chairs
because-
for them to sit,
Correct.
so.
So maybe when we're rounding individually, individual members of the team, just to take that moment to sit down and try to connect with the patient on that level. This article was a Sentinel event alert put out by the Joint Commission. It talked about contributing factors to handoff communication breakdowns, which include insufficient or misleading information, absence of safety culture, ineffective communication methods, lack of time, poor timing between the sender and receiver, interruptions and distractions, and lack of standardized procedures and insufficient staffing, which I think we've experienced. We can relate to some of those things, just in trying to get morning report with our interruptions and stuff. Actions suggested by the Joint Commission include demonstrating leadership's commitment to successful handoffs and safety culture, in ways of focusing on improving organizational systems rather than individual errors, or something that was pointed out in that area, in providing support, time, and resources for handoff quality, making successful handoffs a priority within the organization, and safety a priority. 2, standardizing critical content that needs to be communicated, using standardized tools, conducting handoff communication in locations that are free of interruptions, and including the multidisciplinary team and patient family when appropriate, standardizing training on how conduct successful handoffs, use of electronic health records, monitoring for success of our interventions and using those lessons to drive our improvement, and then sustaining and spreading best practice and making handoffs a cultural priority. So this is a tool I came across while looking into all this. The Joint Commission Center for Transforming Healthcare website, some of you are probably familiar with it and have utilized it. In 2009, 10 of the center's collaborating hospitals partnered with some other systems to begin a project focusing on handoff communication problems. They started by identifying barriers and problems causing ineffective communication, and then they identified, implemented, and validated solutions and piloted processes for other organizations. And what they found is that those participating in fully implementing the solutions that were recommended were able to experience a 50% reduction in the defective handoffs that they had. They also reported an increase in patient, family, and staff satisfaction and successful transfers to other facilities. This is the tool that they use that was developed from that collaboration. It's available on the Joint Commission's website, and it's actually free for any accredited facility to participate in. So it's the Joint Commission's handoff communication tool, targeted solution tool. It takes about 16 weeks to accomplish. It facilitates examining our current handoff process, provides us with a measurement system, identifies areas that we can focus on, and then provides us with some customizable data that we can use to start implementing some of the processes that would improve our communication. So it's very tailored to individual facilities rather than a one-size-fits-all tool. Recommendations after having gone through, this research is that we begin with just some very basic evidence-based improvement strategies, which I think are very practical and real that we could use and maybe see some results. And that would be things like listening to patients without interrupting them. One of the studies showed that most often patients are interrupted within the first 23 seconds of a conversation. How are you doing today? What do you need? And they begin to tell us, and it's just our natural tendency to respond, and sometimes before they're completely finished with their thought. In most of those situations, the patient doesn't go back and elaborate, so I found that interesting. Sitting down to have conversations and connect with patients, assuming, again, as I said earlier, that the patient has more to address than initially voiced. Maybe using words like, I had mentioned, is there something else that you have to address rather than, is there anything else you need? Physicians can use that bathe technique, which I went through earlier during visits, to be reassuring and again improve satisfaction. The bathe technique helped patients feel that their provider was concerned about them and sympathetic to them. Adoption of a mnemonic framework like SBAR or IPASS, and assessing and utilizing the Joint Commission's handoff communication tool. How would you guys say any of these, did you guys learn anything from this? Is there anything that you feel might be able to be used in our practices here at the hospital?
Well, I know we use SBAR. We use SBAR. That IPASS was new to me. I've not
Yeah, there's,
seen it before.
yeah, I've known of iPass and there's other mnemonics that are helpful too, but I think SBAR we agreed on. It seems effective.
Do you think we're using it consistently?
No.
No.
And then, how many of you have an awareness of the role that communication plays in medical errors and adverse events? Did you learn anything new? And were any of the statistics surprising to you?
I guess the number.
Yeah, the number of
I was
deaths.
gonna say, because they were to me, probably not to you, Deb, because you're in quality
Yeah,
risk, so you
yeah,
see
'cause
it
I
all the
see-
time.
Well, I've seen these numbers
But,
in the past as well, so,
yeah.
but it just kinda goes to show you that sometimes we downplay what we have, but the data is
Right.
the data.
Proof is in the data.
Yeah.
That was what was really surprising to me, is that, and then to know that we do have that tendency to downplay, to recognize that all of us really, when we're faced with those questions and we answer, the tendency is to say, it's not that bad, or we do pretty good in this area, or this area, but in reality, one error, if it could have been prevented, is, you know,
There's one too
there's a
many.
system problem that maybe we could work on then. I have here further evaluation of the recommendations offered would be measured by his satisfaction and safety scores. We can use facility dashboards to track the effectiveness of interventions that we have on things like patient satisfaction, readmissions, and medical errors, by comparing our scores to those, of course, after
I think it would be
interventions.
interesting to have Nicole do the bathe thing. Just to
She'd
see.
probably wanna wring my neck.
But
Don't
to see
tell her.
what a difference it would make.
Sure.
You know, and now we have opportunity to try something and see if we can really impact our scores for the doctors.
Sure.
You know, I would try it if I was a provider.
Yeah.
What does it stand for?
It stands for, I have to pull it up here again, background, effect, trouble, and empathy. So it's like, I have to look at the question, what's going on in your life? How is that affecting you? What troubles you most about it? And then that must be really difficult, you know, helping, you know, sitting down and just, it was like
Like having
it
caring
came
and
out of like a
compassion.
psychology, study that they had done and found that it really was impactful to how patients felt cared. And
Well, we know when we round and we use a certain phrase, it impacts our scores.
yeah, there are.
So, I mean, it does
That kind
work.
of goes along with relate to,
Yeah.
Right,
you know, it's
Yeah.
kind of that L,
Exactly.
listening, but then triggering them to give you more information.
right, yeah. So expected outcomes, I've gone over all of these already, improving satisfaction, admission rates, improved exchange of information, and ultimately reduction in medical errors and some no events would be the expected outcomes. So in conclusion, patient safety is everyone's responsibility. As we know, research has shown that communication errors are a major contributing factor in preventable medical errors. And that the use of standardized tools and practices have effectively shown to reduce miscommunication and improve patient safety. None of the recommendations mentioned in the project cost anything, all free of use. So I challenge us to say no to preventable errors and join many of organizations who have partnered with the Joint Commission in improving handoff communication. And then here are the references that I have used in there. That's everything, so.